So let's go on and talk a little bit about, alternative targets. We've been used to using CD20-based therapies for years now, since the introduction of rituximab. And I think it was 1997. It's been a long time since that was introduced. But there are other B-cell targets. For instance, polatuzumab targets CD79B, which is part of the B-cell receptor complex. Other B-cell targets include CD19. So to me, CD19 is an attractive target because it's expressed broadly in B-cell malignancies. I think the other, and not expressed really outside of B-cell lineage cells. So when cells mature and become plasma cells, they start to lose CD19 expression. It is on, like many other, like CD20, it is expressed on healthy B cells as well. And so, when we target that, we could expect loss of CD19 circulating cells in our blood. I mean, this has really made itself clear with CAR T cells. One of the markers there is that when you can't find CD19 positive cells, hopefully the CAR T cells are still present. Have you been working with any of the CD19 directed therapies? I know you've been working with the CAR T cells. So.
Yeah, and by the way, thanks for reminding me how long we've been working with rituximab. That made me feel old, so I don't appreciate that necessarily. But anyway, the good news is we have new things to talk about, and that'll help perhaps us feel younger, I suppose. And I think the CD19 agents are interesting and appealing. We've been working with those, as obviously you have as well. CD19 is very important for B-cell receptor signaling, and so it's a natural target, I think, for treating patients who have B-cell malignancies. And, most of our work to this point has largely been targeting CD19 with chimeric antigen receptor T cells. And I think that has been, as we all know, a game changer, certainly for people that have had a diffuse large cell lymphoma who have failed an autologous transplant, or perhaps have even been refractory to that type of therapy. This has been a game changer for many of them. The response rates are quite good. They're on the order of, up to 70, 80, 90% with long-term survival, meaning people potentially cured with CAR T-cell therapy, maybe somewhere around the order of 40 to 50% of those patients. CAR T-cells, though, are really not completely, in my opinion, I wonder how you feel, the complete answer. And there's lots of reasons for that. One of the things is what I just mentioned. Still lots of people relapse even after a CAR T-cell treatment. And the toxicity is something that is not insignificant. Many of these people have, as we always talk about, significant complications from cytokine release syndrome, perhaps neurotoxicity, and that's not to mention the requirement for hospitalization and for, of course, recognizing the cost of treatment. So we've been working with CAR T cells. They've been a major advance, but we need to continue to do better, and we do need more agents. What's your experience been with the CAR T cells, Ian?
I think it's similar. I mean, I think before the introduction of CAR T cells, basically we would have told patients, unfortunately, there's no real curative therapy for you. Our goals are palliative. Now, at least we have that. We have the hope of curing, as you say, maybe 40% of patients with relapsed after an autologous transplant, refractory to frontline therapy. And so that's a huge advancement, but it also points out some of the issues, which you've mentioned. It's not for everybody, right? I mean, there are significant risks of cytokine release syndrome, risks of, and we're getting better at that, how to treat that, how to moderate, mitigate some of those side effects. But the neurotoxicity is actually quite, impressive for some patients, and it can be pretty scary for patients. And so, unfortunately, not all patients, maybe it's a minority of patients, honestly, who have relapsed and refractory large cell lymphoma are really good candidates for, or ultimately benefit from this very impressive form of therapy. Now, the good news is that, that these next generation CAR T cells look like they're getting better and better. We're getting smarter about treating some of the side effects and trying to prevent some of these adverse events. But it's still, there's some logistic hurdles. I mean, at least at our center, you can't turn this around immediately. You have to screen someone just like you would for a clinical trial, harvest the cells, send them to a central facility where they're reproduced. And so there's a timeline, and unfortunately some people will progress during that, or you just can't wait and have to have some other salvage therapy. And so, you know, in Seattle, you know, is that some of the same hurdles that you're facing, or different hurdles?
You know, I think one of the things that we really forget when we talk about our enthusiasm with CAR T cells is that the people that we're really doing the best with CAR T cells are the ones with a more favorable disease, who have large cell lymphoma. So the unmet need is for those CAR T cells to really help those more aggressive patients. Those are the double hit lymphomas. Those are the ones with MYC rearrangements, double expressors, those ones who have been refractory to their upfront R-CHOP. Those are the ones where we have a major problem even thinking about getting them to a CAR T cell. Or if we can actually get T cells harvested, they progress so rapidly during the 2 to 3 weeks when we're engineering those cells, just like you talked about, that they never get them reinfused. This is something we see not uncommonly. So we need to figure out ways to really approach those more difficult patients, I think, and in particular, those patients who are refractory to their standard upfront chemotherapy. And that's not that uncommon that we see that. It seems like we see it more and more. I don't know if that's really accurate or not. You know, I'd like to know what you think about that. But where I'd love to see us be able to use this technology is in the patients who really, really need it, those people that are more aggressive, more refractory. And maybe we need to be thinking about other therapies for them, and as opposed to the CAR T cell therapies.
Yeah, I'd like to add one other group too, right? There's a group that, you know, the same group that you couldn't take to a transplant. Oftentimes they're the same group that you can't take to a CAR T cell. So older patients, patients with heart conditions, patients with, you know, lung conditions. There's a whole group of patients that, you know, I don't even think come into our centers, because the referring doctors are like, that's just not going to fly. You know, I know that, and so they do their best what they can at their local institution in their offices. And so there's certainly a need for better tolerated, less aggressive therapies to help our patients, those patients that are not eligible for CAR T cells, not eligible for stem cell transplant.
Yeah, and you know, you mentioned, you know, lots of patients are ineligible for a transplant, and you also said that they're often ineligible for a CAR T cell treatment. And I agree with that. We like to think that the toxicity is less with a CAR T cell therapy, perhaps, than an autologous transplant. I would say that's probably true. There are different trade-offs, different toxicities. But the bigger problem that I have, and I think many people do, is that they're ineligible for a transplant because their disease is too aggressive or refractory. They're not chemosensitive, as you mentioned, but that same thing prevents them from getting to a CAR T cell treatment in many cases.
Yeah, I think you said that very well.